unfortunately.
Hopefully it's not too bad.
Yeah.
So we'll make a start then. Our third presenter for today is going to be Kaylee Molin, and her project title is From Pixels to Prognosis, investigating radiomics features in PSMA PET images for response assessment in metastatic prostate cancer. So Kaylee, take it away.
Hi everyone, my name is Kaylee and my research presentation is called From Pixels to Prognosis, investigating radiomics features in PSMA PET images for response assessment in metastatic prostate cancer. I would like to say thank you to my supervisors, Jake Kendrick and Martin Ebert, for providing me with this research opportunity and for being such great supports over this last semester, and also to Ghulam Mubashir, who will be supervising me over this summer. All right. So let's first take a look at prostate cancer itself. The prostate is a gland found in men, and in 2022 we had over 24,000 new cases of prostate cancer according to the Australian Institute of Health and Welfare. This made up a huge 27% of all cancer diagnoses in men, making it the most common cancer type. In the local state, we have close to 100% survival. However, when the disease metastasizes, this drops down to just 36.4%. After 5 years. This makes it the second highest cause of death in men. This is a very pressing issue with high morbidity and mortality, and it certainly requires additional research to improve the outcomes for these patients. Okay, so how is prostate cancer currently imaged? In its local state, we have transrectal ultrasound imaging, which is specifically designed for imaging the prostate gland. This is an early detection technique, and it is invasive, but it is effective in detecting local disease. We also have multiparametric MRI. This produces high-resolution images of the soft tissues in the prostate, and it combines multiple imaging sequences, such as T2-weighted or diffusion-weighted imaging, producing a high-quality image. When the disease metastasizes, we use bone scintigraphy with CT. This is highly effective as metastatic sites are often within the bones of these patients. However, we have limited resolution for soft tissues. So this brings me to our current gold standard, which is gallium-68 PSMA PET CT imaging. PSMA is prostate-specific membrane antigen, and this is overexpressed in prostate cancer cells. So when we attach a radioactive tracer, we can allow it to bind to these receptors, and then through annihilation reactions and the production of the gamma rays, we can image it via PET. This allows for very high sensitivity and specificity, which makes it the gold standard in imaging of these metastatic lesions. So this is an example of what a PET CT fusion image looks like with PSMA. So we see there's a few hot spots all around, some usual spots like the kidneys as it's processed. However, there are also additional lesion sites, as we can see here and along the spine, and that is highlighted in red in this right image. Okay, so now let's take a look at what is radiomics. Radiomics is defined as the extraction of large volumes of features from medical images. This includes morphological features, so this is measurements derived from the actual dimensions, the shape, and the structure of lesions or tumors. We have textural features. These analyze the spatial arrangement of the pixels in the images, and it provides insights into the internal patterns and can help identify variations in tissue texture, such as smoothness or heterogeneity. We also have functional features. This assesses the dynamic aspects of tissues, such as blood flow or metabolism. So these extracted radiomics features are often used in combination with semantic features. So semantic features are those that are characterized by the radiologist. So for example, the tumor environment, like the size, shape, and location. Radiomics has many advantages, as images are obtained for nearly every cancer patient, with each of these images being a potential source of radiomics databases. From this database, we can create statistical models, which can lead to the development of individualized treatment. Now, radiomics is not a replacement of current methods. It rather complements these traditional methods for better outcomes of these patients. Okay, so there's lots of literature surrounding the topic of radiomics, and many of them agree with these general steps. The first being image acquisition and pre-processing. We need to obtain high quality images and pre-process them before we segment these images. So for example, we might filter them or use gray level discretization, which is where we convert the continuous range of pixel intensities into a finite set of discrete levels or bins. Next is segmentation. This is the most important step of this workflow. This is where we actually define the regions where we will extract the radiomics features from. The next stage, we have image processing. So this homogenizes the images with respect to pixel spacing, gray level intensities, bins of the gray level histogram. And this is important as the robustness of the radiomic features extracted largely depend on the image processing settings used. Our next stage is the actual feature extraction. I will be doing this using a Python package called PyRadiomics, and this is based on IBSI guidelines, which is Image Biomarker Standardization Initiative, and they have defined a number of radiomics features that are relevant. The variables with the highest biological clinical variability should be kept in the model, as these are most representative of the variations between the patients in the cohort. And finally, we have the model development. Machine learning models are used to build these predictive models to correlate the radiomics features with clinical outcomes, for example, overall survival. This step also requires validation, as the model itself needs to be checked against other data sets and making sure it can be generalized to a greater population. So I thought I would show a few examples of the power of radiomics in uses in the last few years. First, a study in 2020 looked at FDG PET-CT images, and they found that they could accurately differentiate between breast carcinoma and breast lymphoma just from the radiomics features. Now, these two diseases appear very similarly in images. However, the radiomics data allowed doctors to differentiate between these two diseases. These two diseases have very different treatments, so this allowed for less misdiagnosis and allowing those patients to receive the treatment that they need. Another study in 2019 was able to predict mild cognitive impairment progression to Alzheimer's disease. And this allowed for the development of personalized precision medicine for those affected by Alzheimer's disease. So these studies highlight the power of radiomics in medicine and the positive outcomes that can be made possible. Finally, this brings me to the aims of my presentation. So just to remind you, my research is called Investigating Radiomics Features in PSMA PET Images for Response Assessment in Metastatic Prostate Cancer. Firstly, I have access to 256 of these images. They're baseline and follow-up images about 6 months apart. The patients in these images may have received a range of therapies such as androgen deprivation therapy, chemotherapy, radiotherapy, or simply acute surveillance where they haven't received treatment. From these images, I will follow that radiomics workflow that I previously mentioned and extract radiomics features. From here, I will include additional clinical features such as Gleason score, which is a measure of disease progression specifically for the prostate. And finally, I will create machine learning models to predict overall survival in these patients. Overall survival refers to the time between diagnosis to the time of death, and it's often used as an indication of how well a treatment is working. All right, so this brings me to the way that machine learning is going to be used in this project. It's very important. So firstly, in the images themselves, they were semi-automatically segmented using convolutional neural networks. Next, once we have extracted the features from these images, we require feature selection and dimensionality reduction, as radiomics extraction often results in very high dimensionality data. We can use machine learning to do this for us. Machine learning allows us to process high dimensionality data that we are not able to do using traditional methods. It also allows us to identify patterns and make predictions using the data itself. Okay, so this brings me to how am I going to be investigating this data? So I am looking at the correlation between radiomics and clinical features and overall survival. Firstly, I will take a look at some non-machine learning techniques, such as univariate analysis, multivariate analysis, Kaplan-Meier statistics, and the Cox proportionality hazards model. Following this, I will look at machine learning techniques. Firstly, I will look at doing a principal component analysis, which will aid in dimensionality reduction. From here, I will test a number of different models for example, linear regression, support vector machine, and random forests. I may even look into using neural networks or deep learning mechanisms depending on the complexity of the data. Okay, now with this project comes a number of challenges. Firstly, the data quality and the quantity. Machine learning models, the quality of them relies on the quality of the data. With PET images, they're fairly high noise and low resolution, which means that this can impact the results of the model. Inter-observer variability is a large challenge here. As I mentioned previously, the lesions were segmented using a convolutional neural network. Then they were corrected by 2 clinicians. There is variability between each person's observations, and because this is the segmentation, this is where we extract the radiomics features from. So variations in the delineations can lead to variations in the extracted features, which will affect the model later on. It is important that the observers, that the delineations are the same throughout all the images. Another challenge is how to handle the multiple lesions. So most patients with metastatic prostate cancer will have multiple lesions across their body. When we extract radiomics features, we will be extracting it from each and every lesion. I will need to investigate, how do we combine these features? Do we take an average? Do we take the minimum, the maximum, or is there another method that is best suited? Next, we have repeatability and generalizability. Sometimes the imaging parameters and the pre-processing settings can actually outweigh the impact of lesion data itself, which means that we need to ensure that the parameters remain constant so that the model can perform as well as possible. Similarly, generalizability, we need to make sure that the model is able to work for other datasets, not just the small dataset that I will have access to. This is a challenge as it is difficult to obtain access to other datasets due to privacy laws and ethics approval. And finally, looking into the future, clinical implementation remains quite a challenge. Radiomics itself is a fairly new field, and it has been growing exponentially in terms of the amount of papers that have been produced. However, there is still a hurdle to clinical implementation due to the requirements for standardized imaging, accurate auto-segmentation techniques, and user-friendly software, as well as the requirement for these pre-trained models. Okay, so now I will look at a literature review on the current studies on metastatic prostate cancer and overall survival. This first study found no correlation between radiomics from PET imaging and overall survival, while this next study, which is most similar to the research that I will be conducting, found a relationship between the standardized uptake value minimum within the lesion and kurtosis as indicators of overall survival. These next 3 studies looked at castration-resistant prostate cancer. This is a form of prostate cancer where the patient no longer responds to traditional treatment. Some of these studies were inconclusive, while this third study found that clinical features in combination with radiomics features proved most successful, and this is what I am planning to do in my study. This research here looked at bone metastases in the pelvic region, which is a common site of metastatic site. They found that LDH, which is lactate dehydrogenase, as well as hemoglobin, which are both from blood tests, as well as the max 2D diameter, were identified as indicative of overall survival. And finally, this study looked at TLV auto, which was the total lesional volume, and also TLU auto, which was the summing up all the SUVs of the voxels, and that was found to be indicative of overall survival. So what this shows us is these studies represent a fairly inconclusive and ununified results. So we require additional research in this field to find, is there a correlation between these PET images and overall survival? Something to note here is that the number of patients is generally quite small, which could have skewed results. So now I'll take a look at my study plan. I'm currently here at about to start number 5 after receiving ethics approval. Following this, I will be trialing the machine learning models after investigating all of this data, followed by an outcome analysis and hopefully an external validation if this is possible. If time permits, I will look at exploring other clinical outcomes besides overall survival. And finally, this brings me to the actual thesis writing and presentation preparation. Here are my references, and thanks for listening.
Great, Kaylee. Thanks for that presentation. That was fantastic. Does anyone have any questions? If they do, please put their hands up. Mubasha, go for it.
Hi, Kaylee. Good presentation. Just one question that actually, when you're talking about the lesions in different parts of the body, does it differ if it is in the different spaces, like in the different part of the body? Does it differ from each other, or the features vary or not? Is there any study about it? Have you got it?
At this stage, I haven't investigated the data itself yet. I've just received ethics approval, but I haven't had a chance to look at it. But what I would think is that the lesions in different locations, they may hold different features. If the lesions are similar size and similar progression, then possibly that the features will be quite similar between them, but it will require further investigation from me to be able to answer that properly.
Yeah, so have you got anything in the literature? I'm just asking, curious to know.
I found a few studies on handling multiple lesions for lung cancer. And they found that, I believe, taking the minimum of some of the features that were extracted was very beneficial for the project. So I will be trialing many different methods to see what is the best way to handle these multiple lesions, or maybe even using each lesion itself as like treating them individually and seeing if I can create models for each one, which would prove more difficult, but it's something I will be looking into.
Okay, thanks.
Martin, got a question?
Perhaps Roger before me.
All right, Roger, go for it.
Kaylee, that was a really, really nice talk. Thank you very much.
Thank you.
And I've got a very quick and possibly ignorant question. These radiopharmaceutical images do produce artifacts to some extent. Well,
Yes.
not artifacts so much as, but they identify tissues which are not relevant because PSMA is not, unfortunately, totally restricted to the prostate and its metastases. You may have covered this, but how do you eliminate that kind of background noise, if you like?
Yeah, it's a good question. With the model itself, the model is susceptible to artifacts. However, with the automatic segmentation, what happens is the model looks at the images and segments these regions, and then from there we had two clinicians looking at these images and correcting them. So they have that experience. So I would think that they could like unselect those regions where we have the like incorrect sites. However, you can't always tell, which means that we would have extraction of radiomics features from places which actually aren't metastatic sites. So it would introduce a bit of complexity into it, and it's something I will look into further during my research.
Thank you.
Martin, do you want to jump in now?
Yeah, so my question was quite similar to Mubasha's, I guess, in terms of the levels of complexity. So the features might actually be dependent on the spatial location, whether it's a bone metastasis or not, how many there are, etc. And you sort of alluded to that in your talk. I'm wondering if maybe some sort of unsupervised clustering method might help to sort all that to some extent. Do you know much about those methods at all and whether they might be applicable?
Yeah, I was thinking about using that as like a preliminary analysis and see if we can like group the similar lesions or similar types of features extracted. Yeah, that is definitely something to consider, where I could cluster those similar sites or similar features together and maybe do it that way. Yeah.
Fantastic. I think we'll leave it there. So Kaylee, thank you for that excellent presentation. If you don't mind, stop sharing your screen. Thank you.
Thank you.